Respected chairpersons and panelists of this session, learned participants, Assalamu alaikum. I am Dr. Mohammad Atikur Rahman from NICVD, would like to present a case of primary PCI. Title of my case is Double Jeopardy during primary PCI. This is short history of my patient. She is 56-year-old housewife, developed sudden severe central chest pain for 6 hours radiating to the left arm and neck. She was on antihypertensive for last 10 years and she had strong family history of ischemic heart disease. On examination, her pulse was 64 beats per minute, regular, blood pressure was 105/60 millimeter mercury, precordium and other systemic examination was normal. This was her first ECG showing there is ST elevation in 2, 3 and ABF lead with pathological Q in lead 3 and ABF, with ST elevation in lead 2 is less than lead 3 and ST depletion in lead AVL. Heart rate here is 60 beats per minute and regular. This is right-sided ECG done a bit later and there is no ST elevation in V4R and T is upright. The patient was decided to have primary angioplasty and we rushed the patient into the cath lab, and as the culprit lesion is likely to be in the RCA, we cannulate the left main first. Left-sided angiogram showing left main is normal. There is non-critical plaque in the LCX. And 70 to 80% lesion in the distal LED. We took GR6 French catheter, guiding catheter directly to cannulate the RCA, and we are a bit surprised seeing that there is 2 lesions. One is at the osteoproximal part and another is at the distal RCA, just before the bifurcation. This is another view. And we were in doubt whether the proximal lesion is the spasm or true lesion. So we gave in nitroglycerin 200 microgram and taken another check. But the lesion persisted and thereafter we disengage the catheter and take one non-selective view and the lesion still persisted. So the lesion is true. We were in dilemma which lesion to address first, the osteoproximal lesion or the distal lesion. We planned for the distal lesion to address first because we are thinking that the primary culprit lesion is the distal lesion that makes the inferior MI. But as the proximal lesion is very tight, nearly 99% lesion, so we planned for pre-dilatation of the proximal lesion before stenting of the culprit lesion, that is distal lesion. After taking the wire, we immediately dilate with a 2.0 into 15 P-balloon, air time 2.0 into 15 balloon. This is the check CD after balloon, P-balloon. And we are in dilemma whether the second wire in the PDA is essential or not. But finally, we took second wire to protect the PDA, as there is some lesion in the osteoproximal part of the PLV and PDA as well. But they are developed dissection in the proximal lesion. Though this is type B dissection, but we again were in dilemma which lesion to be stented first, the proximal or distal. As the MI occurred due to the distal lesion, so we planned for stenting the distal lesion first because there will be only a matter of couple of minutes to stent the distal lesion. And as the decision was iatrogenic and still in the type B, so we planned for stenting the distal lesion first. We took resolute integrity 2.5 into 30 millimeter stents covering the proximal part of the PLV from distal RCA, and stent was deployed. Then the flow became diminished. We taken out the balloon. Taken the gel wire as well, but the flow further diminished. And we passed the balloon through the whole vessel up to the distal end of the distal stent. The flow didn't improve, but we can recognize the distal landing zone for the proximal stent. Thereafter, we took the second stent, that is resolute integrity again, 3.0 into 22 millimeter, covering the ostium. Stent is being deployed. And this is the scene after the stent deployment. This wire is still inside, and after removal of the wire.
8 feet is over. I think you do fast.
Now, there are some questions to be answered. Which lesion to address first? That was our first question. Could the pre-dilatation of the proximal lesion be avoided, as we are thinking that it was 99%? When to negotiate the second wire, before or after pre-dilatation of the proximal lesion? We put it after pre-dilatation of the proximal lesion. And after observing dissection in the proximal lesion site, was it better to deploy proximal stent first? What could be done instead and or in addition? Thank you. Thank you for your patient sharing.
Thank you, Dr. Atik, for your nice presentation, double zero parity in primary PCI. For the kind information of the chairpersons of the session, you must put marks for every candidate for the reward of this session. Thank you, Dr. Atik. Now, can I ask or request Professor Fazilul Malik to comment something about what should be after dissection, whether the before pre-dilatation passing of the second wire is it essential, or if I wants to put a second wire, is it ideal to escalate it before pre-dilatation of the ostial segment? And second thing is that after when he saw there is dissection, is it ideal to push any dye to accelerate the dissection? Professor Fazilul Malik, thank you.
Thank you for inviting me to this very interesting session. And first of all, I congratulate our first speaker for presenting a very interesting case. However, for the later speakers, I want to also say that you have to be on time, because that is also going to be judged. that your presentation should be spot on and you have to finish by time. So that we have to look. And this case obviously raise a lot of questions that the presenter has already himself addressed or wanted to, has posed as questions. As Professor Shuid has rightly pointed out, there were quite a lot of things and ifs and buts in this case. But what if we had done like this? What if we had done this? So you see, the fact is there is no absolute right or wrong. So the operator at that time or point did what he thought was the best for his patient. And this is one of the things about interventional cardiology. It is not an absolute science. We try to do the best for our patient at that point of time. Retrospectively, now looking at this case, maybe some of us would have put the stent first in the proximal part. Some of us may, when they saw the dissection, some of us would not have wired. So it is all, like, what if I had done this? What if I had not done this? But so there were lots of questions, and that is good. But the good thing is that our operator came out safely from the case, and he has to be congratulated for that. Maybe I would have done it differently. Someone else would have done it differently. But congratulations on presenting a very interesting case. Thank you.
Thank you, Professor Faziluddin Nasa Malik. Madam, I like to add, you have already told, even then I like to add that after seeing a dissection, we should have to use dye cautiously. We shall have to take as minimum as possible CNS because it may cause progression of the dissection. That is why the Khandakar Shahid also noted these points, 2 points. One is the taking multiple views after dissection. It should be avoided as far as possible. And another question Professor Khandakar Shahid told that whether we should stand distal one first or proximal one first. Here there is no hard and fast rule, madam, you have told very nicely, but as far as possible we want to deliver the distal stand first and proximal stand second, as because there should be a stand proximally, and if I have to give another big stand distally, then it may cause problem to enter into the proximal stand. That is why we like to do, but there is no hard and fast rule. Thank you, madam. Now, Shahid, Khandakar Shahid. Khandakar Shahid. Next.
I think better to discuss after presenting all the cases. I like to request the second presenter, better late than never to or earlier, Dr. S.M. Mamun Iqbal. Share your screen and go ahead.
Respected chairperson and the panelist, assalamu alaikum. I am welcoming you all to today's presentation. My topic is better late than earlier or never in case of STEMI. So this gentleman, Mr. SB, a 40-year-old gentleman, presented with severe compressive chest pain for 1 day. He was a smoker, non-diabetic and normotensive. He did not give any history of any prior angina. On examination, he was hemodynamically stable and there was no feature of heart failure. This was his ECG. It showed pathological Q in 2, 3 and AVF. And there was some J-point elevation in V3, 4 and 5, and also a tall R in V2. So our diagnosis was it is a case of STEMI inferior. The echocardiogram showed the inferior posterior and lateral walls were severely hypokinetic, and the anteroseptum, apex, and anterior wall were moderately hypokinetic. His serum creatinine level was 1.6 milligram per dl. His troponin I was positive. As per the guideline, it is a class 2A indication to go for a routine primary PCI in case of a patient who do not have any features of ongoing ischemia but still presenting after 12 hours of onset of pain. So we went for the coronary angiogram. It showed that the L6 is non-dominant, normal. In the LAD, there is a 011 lesion involving the LAD. Also involving the diagonal. This is a bifurcation lesion. And in the RC is totally occluded by a thrombotic lesion. So we have a multivessel disease in a young gentleman on us. So the issues involved here is a patient presenting after 12 hours, which itself is a class 2A indication for going for a primary PCI. He had a renal impairment. We had a lot of discussion in the previous session about the infracranial artery only or complete revascularization approach, and different trials have concluded that complete revascularization reduces the MACE, but there is no definite point or definite time period for doing this test procedure. Some says that it should be done within the indexed hospitalization, some says it should be done as a staged procedure. So firstly, we went for the primary PCI. We could not negotiate a BMWR, so we went with a whisper wire and a JR guide catheter. We pre-dilated the lesion with a 210 millimeter NC balloon. The pre-dilatation didn't give much of a good result, so we went for a manual thrombus aspiration. So after the thrombus aspiration, we could see the distal landing zone, and we deployed a 3.5 into 28 millimeter bare metal stent in this case. Then we went for a post dilatation with 4 into 10 millimeter NC balloon, and this is the final result, which shows TIMI 3 flow and a big dominant RC. Now the question comes, when should we do the stage procedure? So taking into account the renal failure, we decided to discharge the patient and again to follow up the patient after 2 weeks. After 2 weeks, we saw that the serum creatinine level was 1.4, which is within the limit of our laboratory range. So we discussed with the patient and we decided to go for the LED bifurcation lesion PCI. So we took a XB 7 French guiding through a femoral approach. We passed 2 wires, 2 BMW wires, one into the diagonal, one into the LED. We pre-dilated first the diagonal and the LED with a 215 millimeter balloon inflated at 10 atmosphere. This was the result after pre-dilatation. And then we deployed a 3 into 12 millimeter of drug-eluting stent in the diagonal, keeping a 3 into 15 millimeter of NC balloon in the LED. Then the whole system from the diagonal was taken out, keeping the balloon in LED. We inflated the balloon and did the first brush. The balloon was 3 into 15 millimeter balloon in the LED. We inflated it at 16 atmosphere. Then the ostial strut of the diagonal was recrossed and the strut was reopened with a 3 into 15 millimeter balloon. The first case was done with a 315 millimeter balloon in the diagonal and a 310 millimeter balloon, 315 millimeter balloon in the LED. And the whole system from the diagonal was again taken out. We then deployed a 3 into 32 millimeter of drug-eluting stent in the LED and inflated at 16 atmosphere. And this deployment acted as a second crush of the diagonal stent. We did the pot with a 3.5 into 15 millimeter balloon. After doing the pot, we recrossed the diagonal stent with the BMW wire. We opened up the strut, ostial strut of the diagonal. And we did the second case with a 315 millimeter balloon in the diagonal and 315 millimeter balloon in the LAD. Both were NC balloons. We inflated at 12 atmosphere. Now we did the final part with a 3.5 into 15 millimeter balloon inflated at 16 atmosphere. This was the final result, a leocranial view showing good ostial result of the diagonal and good telemetry flow. There were no complications. We followed up the patient. The patient recovered well, went home. He came back after 40 days. After 40 days, the echocardiography shows the inferior, posterior, and lateral wall were still hypokinetic, but the ejection fraction has increased to 45 to 50%. Is functionally was well, and the hypokinetic LAD territory was gone now. So thank you very much for giving me the opportunity. Thank you, sir.
Thank you. Thank you, Mamun, for a nice presentation. We will discuss for some times. Sometimes we will spend, and we like to hear from the chairperson at the last, because there is a lot of course, a lot of case, and before namaz it should be finished. So our third presenter, Chan Singh from BSCI. Teenage heart is always mysterious. Teenage heart is always mysterious.
Sir, am I audible, sir?
Yes.
Sir, Honorable Chairperson, respected panelists and learned audience, welcome to everybody on today's virtual meeting. I am Dr. Charan Singha. Before going to my presentation, I must pay deep respect and feelings to the person who have died in this corona crisis. You know, teenage heart is always mysterious, as they are thinking, and curiosity is always there. My patient, a 17-year-old female, she admitted into our emergency department with central severe chest pain, and she had no history of a risk factor for coronary artery disease or positive family history of premature cardiovascular event. She had a history of non-ST elevated MI 5 months back. Her baseline investigation was normal, but ECG revealed widespread ST depression involving anterior and inferior lead with significant ST elevation in the AVR. Other positive finding was, as she was young, so we extensively evaluated her, and the positive finding was she was mildly anemic, ESR 50 millimeter, peripheral blood film reveals hemolytic anemia, ANA and anti-DS DNA was positive in high titer, urinary reveals 1+ proteinuria, and other thrombophilic screening and rheumatological evaluation was absolutely normal. Then we proceed for coronary angiogram. In the left system, we have found that there is a critical ostial stenosis on the left main, and it was further confirmed by giving nitrate, and the persisting stenosis was seen in the left main ostium. In the right system, we had also found that there is ostial stenosis, critical ostial stenosis in the right coronary artery, and it was further confirmed by giving GTN. So our diagnosis was, this is a case of systemic lupus erythematosus with double vessel coronary artery disease involving both ostium of the left main and right coronary artery. So our plan was to treat our medical condition and revascularization. Accordingly, we proceed through right femoral approach. We engage the right coronary artery through GR6 French guide catheter and negotiate a filter FC wire and pedilate the lesion through 2.2 into 12 millimeter balloon, and then we deployed a 4 into 12 millimeter drag-linking stent, and this is the CNIMS showing the stent deployment in the proximal part, and this is the result of the stent deployment. And obviously we then proceed for post dilatation by 4.5 into 8 millimeter NC balloon, and this is the final result. showing the appreciating result, showing the good TIMI3 flow and good myocardial blush. Then we proceed into the left side system through engaging the left system through GR 3.5 6 French guide catheter and negotiate a fielder FC wire. And we predilate the lesion through 2.2 into 12 millimeter NC balloon. And this is the result of predilatation. It's seen in the different view. And we deployed a 3.5 into 12 millimeter drug-limiting stent. And this is the scene image showing the stent deployment. It was deployed high atmospheric pressure. And then port was done. And this is the final result. Showing the final result, showing the TIMI3 flow and a good myocardial blush. And this is the hardware we had used. Patient was, after the procedure, the hospital stay was uneventful. And patient was relatively all right for 3 hours. Later, she felt on and off exertional chest pain. And her drug compliance was not good. And then she readmitted into our hospital with central severe chest pain 3.5 months later with very low blood pressure. At the time, ECG shows ST wave changes and echo shows inferior hypokinesia. Then check CSG was done. Here shows the there is a significant instant stenosis in the left main with collateral from left system supplying the right system, and the right side shows there is a total occlusion of the right coronary artery. Here shows the total occlusion. So we had undergo heart team approach, and CABG was done according to decision. 2 graft was given, Lima to medial AD and Lima to RCA. And we extensively further counsel the patient and patient's attendants, parents regarding treatment and future outcome. And we detail workup by collaboration with the rheumatological department in our BSMU, and we settled the treatment. And recently patient was very good, and her everything is normal, and SL is inactive with the drug hydroxychloroquine and corticosteroid, and SL is inactive both clinically and biochemically. And we searched the literature extensively. Coronary artery disease generally, there is a different school of thought that it occurred due to atherosclerosis, vasculitis, thrombosis, embolization, spasm. And instead of diffuse atherosclerosis, there is interesting finding that localized atherosclerosis may happen. And patient basically has 7 times greater incidence of coronary artery disease and more than 50 times risk of PMI over the age of 35. And there is inflammatory dysregulated immune response, and drug-induced atherosclerosis may be a responsible cause for premature vascular disease in SLA patient. So my take-home message from the presentation is that no age is immune for critical coronary artery disease, even in left main involvement. And biosteal coronary artery disease is a rare entity, especially in this young age. Revascularization of the osteal stenosis is actually always challenging. And coronary artery disease in young age, non-atherosclerosis cause should be excluded by any means. And treatment of the obviously underlying condition and compliance to the drug is very much important for maintaining the healthy life. I am very much grateful Dr. Ahsan Habib sir, Syed Ali Hassan sir, and Professor Fazlur Rahman sir for preparing the case. And actually, patient is always giving respect to us if we did something to our patient. So thank you very much. Thank you for your patient sharing.
Thank you, Dr. Choyon. Now I am requesting Dr. Dhiman Kahali to comment something about the biosteal stenosis in the young lady with diagnosis SLE. What should be the treatment option, and whether there is any chance of or the feasibility of robotic surgery. Thank you.
শহীদ ভাই আনমিউট হন, আপনি আনমিউট হন।
Now can I request, is the Dhiman Kahali there? Okay, he's absent. Now, can I request Dr. A.P.M. Saurabh to comment something about this, the treatment strategy of this patient, of the young lady? Dr. A.P.M. Saurabh.
Dr. Amal, sorry, Professor Shohid. Professor Shohid.
Yes, sir.
শুনছি স্যার বলেন
ওই ডিসকাশনের মাঝখানে দিয়ে দাও, এখানে দিয়ে দাও।
আচ্ছা শহীদ ভাই তো বলেছে যে ধোঁয়ার কালিকে খুঁজেছে উনি নাই।
প্রফেসর ফজিলা মালিক,
সৌরভ,
প্রফেসর ফজিলা মালিক,
সৌরভ ভাইকে
make a comment. One thing I feel is that since it was an aorta osteolysis, I was imaging might have given us greater insight into what kind of lesion these were and for proper preparation of the lesions, because aorta osteal lesions in many instances, these are quite fibrotic and you might need to use cutting balloons and other tools to get a long-term better result. So I think this is my comment here.
Now, Dr. Tanjina.
Just one comment. Yeah, in this young lady, the very important point is that we have to determine the underlying cause is atherosclerosis or vasculitis due to SLE. That is why after getting the double-strand stenosis, we consider this patient should undergo coronary bypass surgery. Thank you.
Thank you, sir. Now I am requesting Dr. Tanjima Afrin Khan to present his case. Dr. Tanjina Afrin Khan, would you hear me?
Assalamu alaikum.
Yeah.
Can you hear me, sir?
Yes. Okay.
Yes. Go ahead.
Thank you for giving me the opportunity. Assalamu alaikum. I'm Dr. Tunajina from United Hospital. I'm going to present the case. My patient was 63-year-old hypertensive diabetic and dyslipidemic patient with a background history of old anterior STEMI. And during presentation, he had fair LV ejection fraction of 50% with hypokinetic LED territory. This is the coronary angiogram showing bifurcation lesion in the LED and also involvement of the obtuse marginal branch. And the RC also had critical lesion at the ostium of the PLV. So the patient was recommended for revascularization. The coronary angiogram was done in the KSA where he had that MI. The symptom score revealed either CABG or PCI as a revascularization option for this patient, and Euroscore revealed also low mortality at the peri-operative stage in CABG. So what should be the strategy if we go for PCI? Whether the side vessel needs to be preserved. In our case, the diagonal was a very big branch, almost like the similar diameter with the LED, and the ostial lesion in the diagonal was just at the base of the ulcerated plaque in the LED. So there was a highly likelihood that the side branch will be occluded if we go for provisional stenting. So the two-stent strategy was the option here, and also the side branch angulation was less than 70. So our plan was for the DK crush. So, but before going to the PCA, we anticipated some challenge because the entry to the diagonal branch would be very much difficult at the ostial lesion position at the diagonal at the base of the ulcerated plaque. And also there was a high risk of contrast-induced nephropathy. So we took a 7 French guiding catheter at the radial root. It was an XB3. BMW, we tried to negotiate the BMW wire into the LED, but we failed, and LED, and later we used Crusade catheter with a side hole and tried to negotiate the cyan blue into the diagonal, but we failed. Then we pre-dilated the LED lesion with 2 into 15 millimeter safeguard balloon. We kept trying to enter into the diagonal with whisper, filter ST, but we failed. Then we took the microcatheter. And with the help of the microcatheter and filter XT wire, we could negotiate the diagonal. And thereafter, we exchanged the filter XT wire with the BMW wire. Then we pre-dilated the diagonal with a 20-15 millimeter NC balloon. And we did the, actually we simultaneously pre-dilated the diagonal and the LED. Though we have seen it is the first case we have done here, though it is not a provisional first case in case of the decay crush, but we did it before implanting the stent into the diagonal. Then we planned for the IVUS. This is the IVUS distal LED. This is the plaque from the distal LED. We can see the circumferential plaque here. Then this is the proximal part of the LED. And this is the left main. And we did the IVUS in the diagonal too. You can also see the circumferential lesion in the diagonal. This is the ostium of the diagonal. And this is the LED. Then we pre-dilated the diagonal branch with a high pressure with a 20-15 millimeter balloon. And keeping another 20-15 millimeter balloon in the LED, we proceeded with the 2.5 in 20 millimeter drug-eluting stent in the diagonal. And we post-dilated the lesion. Then we crushed the stent, and before that we removed the wire from the diagonal, and we crushed the lesion. We crushed the stent. And then we recrossed the diagonal stent strut with the with the same BMW wire. And we did the second case, which is the provisional first case in case of the decay crush. The wire from the diagonal was removed, and pre-dilatation in the LED was done with a 25 into 15 millimeter balloon with a high pressure. And we implanted 3 into 38 millimeter drug-eluting stent in the LED. We then recrossed the diagonal branch through the stent struts in the LED. And we did the third case. The proximal optimization was done with 4 into 15 millimeter balloon in the proximal part of the stent in LED. This is the angiographic view after the stent implantation in diagonal LED. Angiographically, it was satisfactory, but we confirmed it with IVUS. Nicely opposed stent struts. So complex coronary lesions demand complex procedure. The more complex a procedure is, the more chance is target vessel revascularization, major adverse cardiac event, and instant restenosis. And intracoronary imaging plays vital roles for decision making, minimization of complication, and stent optimization. I acknowledge my teacher, Dr. Rene Mominuzzaman sir, and I thank you all.
Thank you, Dr. Tanzina.
Tunabjina.
Tunarjina. Now, simultaneous balloon inflation. What's the importance or what is the benefit of the simultaneous inflation of the two balloons at a time?
Yes, sir. In case of two-stent strategy in bifurcation lesion, it is needed for optimization of the stent struts at the opening of the side branch and also at the optimization of the two stents with each other with the simultaneous kissing.
No. Before stenting, you did the plain balloon POBA simultaneously. You inflated the balloon of the LED and the diagonal.
That was done just for the as a part of the doing the bed preparation for the stenting.
Professor Fazila Malik, would you comment something about this? The simultaneous kissing or separate simultaneous inflation of the balloon, or the inflation of the side branch and then inflation of the main branch? What is the advantage of these developments?
Actually, what she did, she already mentioned that this kissing was actually optional. The first kissing, it is not in the original DK crush. So basically, first of all, in the DK crush, we have to wire both vessels. And after this, we can do kissing of both vessels as required. Here, we can do ballooning of both vessels. Here, the kissing is not mandatory. So if the lesions are severe, we dilate both the middle vessel lesion as well as the side branch lesion. The kissing comes after the stents have been deployed. Here, this was an optional step. So here they did 3 times kissing rather than the 2 steps which is done in the DK crush. One question for the presenter I wanted to know is, you said that you wired the vessels. So through which strut did you go while you were wiring the side branch?
Thank you, madam. For wiring the side branch, before we strengthened the LED, we went through the distal struts of the side branch. That is after implanting the first stent, where we took out the wear and then crushed it, and then when we recrossed the stents with the BMW wear, we went through the distal struts of the stents.
Actually, I think the operator went through either the proximal or the middle strut.
Yes.
Okay. Because in case of DK crash, if you look at the pathology, you have to go to the proximal strut or the middle strut to get the best results.
Yes.
For other techniques like culotte or tap, you will go to the distal strut. But here it has to be the proximal strut.
Thank you,
Professor Fazila Malik, can I add?
Yes, please.
Regarding her case, there is Professor Shoaid is asking that is whether simultaneous balloon dilation should not be done or should done. Actually, when someone decided that two-stenting strategy, then he or she can be dilated both vessels simultaneously. It can be done. And it is not part of the kissing. It is part of the pre-dilatation of the both vessels.
Professor Mamun Rashid Cesar, এখানে question আসছিল খন্দকার শহীদের থেকে, why this case is and what is the benefit of this? Is not
no, sir, this is not case, sir. Professor Fazila Malik correctly mentioned that this is not part of the kissing of the balloon. This is part of the pre-dilatation of the both vessels before placing the stent. And simultaneously can be done if he decided to go to the double stent technique from very beginning.
Now, Dr. Shoaid is asking whether it should be individual, one by one, or simultaneous. Whether it looks new that simultaneous only balloon inflation for pre-dilatation. Whether one side branch then next main branch, or main branch then side branch. Whether this is right or simultaneous.
Professor Omar, I am saying that simultaneous balloon dilation can be done if operator already decided that he will go to the two-stent strategy. Then only simultaneous balloon dilation can be done in both vessels same time. Otherwise, pre-dilation of the side branch or next the main branch was done.
I like to say something about this.
Yes.
Can I?
Yes.
whenever there is a huge plaque in the diagonal, that is bifurcation lesion, and the decision is to stent strategy. In that case, I did many cases with separate ballooning, what Caesar said, almost said. Once in the diagonal, then in the LED, then I did the same thing. But what I noticed, in many cases, even in single stent strategy, predilation or post-kissing dilatation in side branch, there is a plaque shift from the LED to diagonal. To minimize this plaque shift, Sumit Suji once came to our cath lab. He told me, do the kissing balloon first in case of predilatation. That will save your time, that will save your wearing the, after stent implantation, wearing the diagonal. That is a good strategy. What she did first the, I think Mominazaman did it. She did first the kissing balloon of the diagonal and LED before putting a stent in the diagonal. It is, I also do it now. I have did many cases like this, and that is give me a good result, and I am comfortable with it. So it is what is theoretically double crash, double kiss. It doesn't mean anything. You did it for the benefit of the patient. It is practical. What we did now, it will come into the book later.
Thank you, sir. Thank you, sir. Next, I am requesting Dr. Farhan Ahmed to present his case, zero contrast LED osteal PCI by Markin-Oyer technique.
Respected Chairperson, am I audible, sir?
Yes.
Thank you, sir. Respected Chairperson,
Yes.
moderator, panelist, and my dear audience, Assalamu alaikum. My case is zero contrast LED osteal PCI by Markin-Oyer technique. Cardiovascular diseases account for 53% of all death of CKD patient and remaining the leading cause of death after renal transplantation. But unfortunately, this group of patients regarding cardiovascular management is always very challenging and under-addressed. And coronary angioplasty in this group is always underappreciated due to serious complication like contrast-induced nephropathy. Despite of some established approaches to prevent SIN, including peri-procedural hydration and minimizing contrast volume, PCI in patient with advanced CKD is associated with high risk of SIN and requirement of RRT, leading to underutilization of PCI in this high-risk patient. And morbidity is higher in this group of patients when SIN developed. So to combat this situation, zero contrast PCI and ultra-contrast angiography has been developed and creating a new era in the field of coronary intervention, especially treating those patients with CKD who are suffering from refractory angina and not indicated or fit for cardiac bypass surgery. My case is a 55-year-old gentleman presented with complaints of ongoing compressive chest pain. Patient had history of chronic stable angina for last 1 year. Patient was on treatment. He was smoker, hypertensive, and suffering from CKD stage 4 disease with the EGFR 20 ml per minute per body surface area. And his serum creatine was 4.2 milligram per dl. Echo showed anteroval hypertension and moderate LV systolic dysfunction. So as the patient have persistent chest pain, we decided to go for this patient for benefit ultra low contrast angiography. The idea is to keep the volume of contrast and EGFR ratio below 1 with minimal cine view to delineate the lesion. This is caudal view. And the cranial view showing the significant plaque in the mid part of LED. And RCA was normal. As the lesion is apparently very simple, and after discussion with patient, we want to go for zero contrast PCI 7 days after this angiogram. Meanwhile, we check for any deterioration of CKD, but the patient was stable and his creatinine was stable. Zero contrast PCI is itself a very challenging procedure. Challenge remains in terms of engagement of guide catheter without contrast, wearing of the lesions, as well as stent placement. And meticulous, careful analysis of the previous angiographic view is very important. And previous angiographic film were uploaded to monitor as a guide for the coronary wearing and as well as the coronary catheterization. EBO 7 French guide catheter was engaged in the left main ostium. For further confirmation, you can push 10 to 20 ml of normal saline, which can give a temporal change in ECG and to confirm your engagement in left main ostium. And wearing was done in LED without contrast. 3 floppy were, 1 were negotiated to the lesion to distal LED, another 2 were, 1 is in the diagonal, another were in the LCX. IVAS done. And during IVAS pullback, we decided, determined the safe distal landing zone, and simultaneous cine was taken to see the position of the landing zone, to see the position of the transducer of IVAS, which corresponds to the safe landing zone. But during IVAS pullback, we found that the LED ostium is also diseased. So we need to take care of the LED ostial lesions also, beside the mid lesions in LED. And as the left vein is disease-free, so to prevent unwanted metal load in left main and unwanted jailing to the LCX, we decided to go for precise LED ostial PCI in zero contrast. First of all, we treat the mid lesions as the lesion length is 54 from the ostium to the safe distal landing zone. First of all, we take 2.5 into 38 millimeter stent to cover the mid LED lesion. At this stage of our procedure, we pull back the L6 wire and keep the softer portions of the L6 wire from left main to LCX. The idea is that with the blood flow, this softer portion stuck to the roof of the carina and it mark the ostium of LED. And to check whether we are in position, we inject 1 ml of dye for further confirmation of our position. Post dilatation was done. And we did final check by 2 ml of dye to keep record and check for any complications like distal embolization or cardiac coronary perforation, as IVAS is not appreciate these 2 complications. And final IVAS was done, which also confirmed the ostial placement of the stent. So the challenge of this procedure is guide catheter engagement without contrast administration, wearing of coronary without contrast use, stent positioning in the landing zone determined by IVAS, proper placement of a stent to the ostium, finishing the procedure without any complications. And we are very happy to let you know that this technique was endorsed by the very high index journal and published it this year as a first time marker wire technique used to do this such ostial PCI. So my take home message is ultra contrast angiogram and zero contrast angioplasty is a newer approach to treat patients with high risk of SIM. Significant expertise in IVAS and coronary angioplasty technology is also quite essential. During zero contrast angioplasty of LED ostial PCI, radiopaque portion of the PCI were can be used to make a metallic silhouette for precise LED osteal stand placement. This simple technique may significantly facilitate precise LED osteal PCI without contrast. However, precise positioning of the stand according to the landing zone still remains a challenge. Thank you for your patience hearing, and thank you BSCI for giving me a chance to present in such a wonderful platform. Thank you.
Thank you, Farhana, for a brilliant presentation of a new concept, zero contrast.
Professor, something.
Zero contrast is a very new term and very lucrative term. Everywhere we heard the zero contrast in the imaging area. We like to request the Professor Sorabujjaman and Professor Fazilatunnisa Malik a few words. And Professor Jaman is like, I think you want to say something.
Thank you for giving me opportunity. Actually, this nice presentation by Dr. Farhana, and actually, though term is new, but when I was in fellowship in New Delhi in 2006 to 7. At that time, the operator of India, they actually taught me how to do the angio or PCI with the minimum the dye. And actually, when we engage the LED, lead main or RCA, they taught me without any dye. This type of information I have shared in previous BSCI in a seminar, but actually this is the term is new, but actually the whole world is actually doing this type of work before, especially in our BSMMU with a lot of kidney patient we do and we use little amount of dye during engagement of the late main, because and very little, because actually this is the technical new though this term is new actually, but this is the technical, or everybody should practice this type of approach, because
thank you, Mustafa Jawan. I think good discussion. I am not telling new, but it is the emerging term where the CKD also emerging in the simultaneously, so that it's very much beneficial for the CKD patient. Now I like to request Professor Sorabujjaman to few words about the zero contrast PCI. Sorabujjaman sir, unmute.
Yes, it is individualized. Whether you have to do the case in a case of ESRD on hemodialysis or something, it is better options. I have seen it. I did not do it any cases still now, because I do ESRD patients who are on hemodialysis. I do this sort of patients. I did many angioplasties in this sort of patients, but before procedure, I did the hemodialysis. After procedure, he or she goes for hemodialysis. That is better. And this is really difficult, I think, but zero contrast with the help of IVAS, it is possible. I have seen many people are doing it in the world, in many scenarios. But better, it is always good. I think in country like ours, the patients keep the patients on hemodialysis and do the procedures. And after the procedures, that temporary hemodialysis, if the patient is on temporarily hemodialysis, after the procedures, if the patient settles down, you can take out the catheters, all the hemodialysis catheters, and he or she can leave. I have got many number of cases like this.
Kadir sir, want to say something?
I would like to say something. First of all, I like to congratulate Dr. Farhana for the revealing of new technique and published in an international famous journal. This is a very important issue, because many of the patients with kidney failure comes with the coronary artery disease. In those situations, we need to intervene, because without intervention, in some patients, we cannot control the symptom. So first of all, I appreciate for this presentation. Zero contrast. Basically, it is not zero contrast. It is the ultra low contrast, ultra small use of contrast for the procedure. So she demonstrated, but some limitations are there in this procedure because in doing the zero contrast procedure, IVAS is a very important tool for the evaluation of. So in many centers, there is no IVAS for the evaluation. That is the limitation. But in such situation, this technique we can use without IVAS with minimal use of dye in this patient. The patient who are in hemodialysis, we do not bother for those group of patients because we can increase the number of hemodialysis for the procedure. But those group of CKD patients, they are not hemodialyzed, but this contrast might produce the condition that needs the urgent hemodialysis in this situation. So urgent hemodialysis in this situation increases so many complications, including the infected in our country. That is very important. That infection can jeopardize all the good outcome of our patient. So with this few language, again, I congratulate doctor, and I want to few words about previous presentation. Dr. Toyon presented a very interesting case, very interesting, because that is a case of SLE with osteal stenosis, right? Osteal stenosis. He did not show the syntax score. What was the real syntax score and the indication? In any interventional procedure, it is our duty to find out the underlying etiology. Is the etiology is reversible or not? So in this situation, the etiology is the inflammatory origin. And we cannot stop the inflammatory procedure by putting stent at the ostium of the right and left main coronary artery, which is supplying the 100% blood to the both all cardiac chambers. So in this situation, before doing the intervention, I appreciate that because the procedure was done very effectively and successfully. But the result was what we observed, that is a learning point for us, that right coronary artery developed total occlusion and left coronary artery restenosis was significant. So in this situation, before putting any stent, we should go for the heart team approach, not heart team approach after putting the stent in the patient. We should go for the heart team approach before putting the patient in that situation. With this few language, I thank Dr. Professor Amol Kumar Chaudhary for giving me the chance to say something in this presentation. Thank you very much.
Thank you, sir. We have more focus. I like to ask the Professor Fazila, Madam, what is the role of marker in zero contrast PCI?
Well, he did it to identify the ostia. We usually don't use a marker wire, but in many cases it might be of help. So it's an individual choice, and it did great for her. So great case, and congratulations on a case well done. Zero contrast is indeed a very topical issue nowadays and really does help our patients who benefit from minimum dye. Maximum we use around 20 ml, right? And the IVAS is a great tool for zero contrast.
Thank you, ma'am. Thank you, ma'am. We like to request the next case presenter, deadly billing, a case with highest interventional risk. Associate Professor Abdul Momen, who works in NICBD.
Thank you, sir. Am I audible, sir?
Yes, sir. Yeah, Momen audible. Quick.
Thank you very much, sir. Respected chairperson and learned audience, it's my great pleasure to present in this webinar series. So I am here with a case other than the coronary, a different test. My case is highest interventional risk, an interventional case that has up to 70% per procedural or periprocedural mortality if done within 14 days, 4 to 20% if done after 14 days. Early surgical mortality is 30 to 60%, and if conservative medical treatment is chosen, the survival is only 3% at 1 year. Our case, a 45-year-old gentleman presented with central chest pain for 4 hours, hemodynamically stable, and the ECG shows ST elevation in V1 to V6-1 AVL, and we treated him conservatively with streptokinase therapy. But after 2 days, the patient developed shortness of breath. and the hemodynamic unstable, blood pressure 80/50. There is a pansystolic murmur in the left pasternal area with bilateral basal palpitation. He was treated conservatively, and the echocardiography revealed there is a akinetic anterior wall in all levels. There is a pericardial effusion. LV is dilated, and the LV ejection fraction is around 30 to 35%. And there is a VSR seen in the distal part of the septum with the left to right shunt, and it is evident in all views. The measurement of the VSR is 10 to 11 millimeter, and these are the features of raised LV-EDP with LV diastolic dysfunction. The PPG across the VSR was 52, the PSP measured was 52, and there is a RV dysfunction and severe RV dysfunction, and the TAPSI was 10. After initial hemodynamic improvement, CAG done on 5th day of conservative treatment with hemodynamic support. And this is the CAG report that proximal and mid LAD has 80 to 90% stenosis, and so other vessels are normal. Surgical consultation was taken, but considering the higher risk, the patient party and the surgeons are not ready. We are fortunate enough to continue the conservative treatment for 15 days. During this time, the patient develops swelling of body, mild jaundice, and it is progressively increasing. The blood pressure is 90/60 with off and on inotrope support with IV furosemide. Biochemically normal, but the progressively increasing bilirubin with normal SGPT indicating congestive hepatopathy. So what should be done? Medical therapy, surgery, or intervention? The surgeons are denying. So what are the evidence? The medical therapy, only 3% survival at 1 year. Surgical mortality 30 to 60% depending on the severity. Early surgical repair is challenging. There is a chance of enlargement of VSR. Even with surgical approach, there is a residual shunt, 30 to 37%, and more than 10% require further surgical procedure. And these are the interventional trial. They are the small trial, and in acute phase, within 14 days, the mortality and morbidity up to 70%, and pool data indicate that the mean success rate within 14 days is 90% only, and mortality of average 40%. By contrast, in chronic phase, if after 14 days the myocardial infarction, results are very encouraging with low morbidity and mortality, up to 4 to 20% of mortality with high rate of complete closure. And we proceed for intervention at 17th day of the MI. This is the LV graphic showing there's a VSR in the distal mid part of the septum, and it is away from the aortic valve. We are trying to cross from the arterial system with the Judkins with the floppy with the Terimo at 0.30, and then we cross from aorta, LV across the VSR, RV, and into the pulmonary artery. The wire is in the pulmonary artery. Then we proceed another wire from the venous system, femoral venous system, and the multi-purpose catheter. We parking in the multi-purpose catheter in the pulmonary artery. Through the multi-purpose, we are negotiating the snare. We snared the wire from the arterial system, and then finally we produce a loop in the arteriovenous loop. And through the loop, we pushed a 10 French ASD delivery sheath, and it is very difficult to cross the sheath because there is so much angle. The sheath is from RA to RV, then across the VSR into the LV. But we fail to cross this curve. It is mandatory to park the sheath into the aorta before delivery any device. So, but we attempted to deliver by keeping the sheath in the LV, and when we remove this, the sheath slipped from LV to RV. So this attempt was failed. We changed our strategy. We took a harder wire instead of Terimo wire. 0.34 regular wire was in the pulmonary artery. Then it is against near, and over this stiffer wire, the sheath was moving very smoothly from RV across the VSR to LV to aorta. So this is our the sheath is in the aorta. The echocardiography, if we see the echocardiography, this is the RV, this is the VSR, this is LV, and the sheath is in the aorta. So we are in the right place, and we tried to negotiate the devices, but this time it is failed, as evident that both the disc of the muscular VSD device disc are in the LV. So this attempt is also failed, but this time we succeeded, and because both the discs are on either side of the VSR, and we release the devices. The 16-size amplasar device or muscular VSD device was taken. And these are the per procedural echocardiography sheath in the aorta. Sheath, we push the LV disc, and then we pull the device across the VSR, and we put in the VSR appropriately. So this is very important. Echocardiography guidance is very important for proper visualization. So there is no residual shunt seen, so we release the device. Purpose patient was inotrope throughout the procedure on 90% SpO2 with high flow oxygen, occasional VC, no VT, and the patient was under conscious sedation, heparinization with ACT. The patient was feeling comfortable for very beginning, will be stabilized within 3 hours, inotrope stopped on 12 hours, SpO2 98 on 2 liters of oxygen, and it is discontinued oxygen on the next day. Patient shipped on the 3rd day to the ward. Patient was discharged with conservative treatment. So this is the pre-discharge echocardiography. There is no residual shunt, and still there is a pericardial effusion, and there is no residual shunt. And the PSP decreased from 52 to 45. TAPC, the RV function, recovered very well within 3 or 4 days, and this is the pre-discharge smile of the patient. This is the echocardiography after 3 months. There is no residual shunt, no pericardial effusion. The LV function recovered well. The LV ejection fraction around 35 to 40, and most strikingly, the PSP, which was 52 before, and it is 30 after the procedure. 3 months of that. It is more than 8 months. The patient is doing well. No chest pain, no shortness of breath on ordinary activity, doing his business work with full swing. So my take-home message: treatment of a post-MI VSR remains a major challenge. With medical therapy, 6 months survival is very low, but surgery or intervention may provide a complete cure even with high procedural risk. Device closure of VSR can be a true alternative to the standard surgical approach in selected patients. As procedural risk is high, expert hands are mandatory. This is my acknowledgement. Professor Sabina Hashem, who referred me the case, Professor Dr. Ataul Haq, who actively participated in this procedure and actively helped me, and Professor Mir Jamaluddin sir for overall support and encouragement. Thank you, the whole team. Thank you for giving me the chance in this webinar. Thank you, sir.
Thank you, Dr. Momen, for your nice case presentation. Deadly dealings of dead patients, almost dead patients. Now I am requesting the Professor Nazir Ahmed sir for his comment about this case. Professor Nazir Ahmed, do you hear me? Probably he's not here. Muhammad Shafiq, Dr. Abu Muhammad Shafiq, Dr. Mahabur Rahman. Okay, nobody here. So from
right, I'm here.
Shafiq.
Yeah. Thank you, Shuid bhai. This is very nice case I have seen ever. This is really difficult job he has done. I have seen a few patients having VSR. The surgical interventions is very difficult, and most of the patients died in the OT table. And before going to cath lab, so many patients succumbed into death. So this is definitely a very good case. Thank you, Momen, for giving us the opportunity to see this case as well, so we can try it in later on. Thank you very much.
Now I am requesting Dr. CM Shaheen Kabir to present his case. Keep calm and don't inject. Dr. Shaheen Kabir.
Yes, Assalamu alaikum and good morning. My name is CM Shaheen Kabir. I am working as Associate Professor and Consultant in Ibrahim Cardiac Hospital and Research Institute. It's my pleasure to present this case in this webinar organized by BSCI. So my title is Keep Calm and Don't Inject. I do not have any potential conflict of interest. This is my acknowledgement to Professor Maximul Haq and Professor Saidur Rahman Khan. So my case is a 67-year-old male patient with history of diabetes, hypertension, and tobacco use, presented to emergency department with central chest pain. Initial ECG showed sinus rhythm with ST segment depression in V2 to V6, 2, 3, and AVF. Cardiac troponin I was elevated. The patient was hemodynamically stable. There were some improvements of symptoms after administration of aspirin, ticagrelor, enoxaparin, and intravenous nitroglycerin. Echo revealed LV ejection fraction of 55% with inferior hypokinesia. The patient was diagnosed as a case of non-ST-ACS. We have considered early invasive strategy for this patient. So coronary angiogram was started with right radial access with 6 French sheath and 5 French Tiger catheter. And it begins with a radial artery dissection. You can see dilated contrast injection through the sheath revealed dissection in radial artery as resistance was failed after advancing few centimeters of 0 to 1 wire. In this case, the dissection was dealt with by continuing the procedure through the same radial artery access. A true lumen wire advancement was crucial, therefore we preferred to use the 0 on 4 wire to cross the dissection of radial artery. 5 French Tiger catheters advanced over the coronary wire and the angiogram was continued through the same access. Now come to left coronary artery angiogram. It was difficult to engage the left system by Tiger catheter. Apparently there is no disease in LAD and LCX. This is the coronary angiogram of right coronary artery. There is mild disease in its proximal and distal part. Almost no significant disease in right coronary artery. As the left main stem was short, it was difficult to engage the left system by Tiger catheter. The operator took a Judkins left 5 French diagnostic catheter to select the left system. And catastrophe happens. You can see there is diagnostic catheter induced dissection of a normal LAD artery in the ostium of the LAD. You can see a flap in the ostial LAD. So I can believe I just did that. Even Messi couldn't believe when he missed the penalty in World Cup final against Iceland. So things in mind at that time: life-threatening complication, need help from colleagues, provision of stenting, IVAS examination, and what is the culprit lesion for non-ST-ACS, as well as at that time I need surgical backup also. By this time, the patient had rapid clinical deterioration. He became tachycardic and hypotensive. There was ST segment elevation in ECG. His systolic blood pressure down to 40s. So I planned, the whole scenario was explained to the patient attendant, and after stabilizing the patient transiently with fluids and inotropes, we decided to do PCI to LAD. Using gel 3.06 French guide catheter and cyan blue guide wire, the LAD artery was crossed cautiously. IVAS of LAD showing evidence of coronary artery dissection. Intimal flap delineates true and false lumen. So a 3.5 into 24 millimeter dress was advanced in LAD directly. However, you can see an OM branch was occluded, which was the culprit lesion for non-ST-ACS. Stent was deployed directly at 16 atmosphere in LAD. Post-dilation was done by 3.5 into 15 millimeter NC balloon at 20 atmosphere. And final result of LAD, there is no dissection. So don't forget, we have to intervene the OM also. As the patient was stable, we decided to do PCI to OM branch, which was a culprit lesion. You can see there is occluded OM. Occluded OM was crossed with another cyan blue guide wire. Pre-dilation was done by 2.0 into 10 millimeter balloon. And the stent 2.5 into 18 millimeter was advanced in OM branch and inflated at 16 atmosphere. So TIMI3 flow achieved in OM branch. However, there is some haziness distal to the LED stent. There is some haziness distal to the LED stent, you can see. So another complication, dissection at distal stent edge of LED. It was persisted after a dose of 100 microgram of intracoronary nitroglycerin injection. So another 3.0 into 24 millimeter drug loading stent was advanced after rearing the LED. Stent was then deployed directly at 22 atmosphere, overlapping with the proximal LED stent and providing complete coverage of the edge dissection. Overlap segment was post-dilated by stent balloon. And great rib, there is no dissection. So final result after IVAS optimization, TIMI3 flow and LED and LCX. So what about the fate of radial artery dissection? After completing the PCI, the guide catheter was removed over the J-wire and the final angiogram of the radial artery was performed through the sheath. There was normal flow in the radial artery. The catheter works as an internal hemostatic device and helps seal the dissection of radial artery. So we all know the classification of dissection type A, B, C, D, E, and F. The non-coaxial element of the catheter, contact of catheter with the plaque, vigorous contact injection, and the deep intubation of the catheter are the risk factor for catheter-induced coronary artery dissection of my case. So for prevention, we can use appropriately sized and shaped catheter. We can avoid contrast injection forcefully. Contrast should not be injected if the pressure is damped, and we can avoid deep intubation to avoid catheter-induced coronary artery dissection. This is the algorithm. I will go through details. When there is iatrogenic coronary artery dissection, no further antegrade injection is mandatory. Institute appropriate hemodynamic support and use a passive guide catheter to avoid deep engagement. Attempt wiring a true lumen with a non-hydrophilic wire. If wire in the true lumen, stent implantation with complete coverage. If there is residual dissection, we can give additional stent, we can observe, or we can use cutting balloon. If the wire in the false lumen with the guidance of IVAS, we can rewire and we can stent implant. And if not possible, then we can adopt conservative management or cabbage, or we can adopt some payload strategies like retrograde approach, re-entry with stingray, and wire-based dissection re-entry. So now come to what is stent edge dissection. Edge dissection is defined as a linear rim of tissue adjacent to a stent edge with a width of more than 200 micrometer. The prevalence is 6.6% per lesion. This is the OCT classification of edge dissection. It is classified as flaps, cavities, double lumen dissection, and fissures. And this is the IVAS classification of edge dissection. This is classified as intimal dissection, medial dissection, intramural hematoma, and extramedial injury. The vessel overstretching and the presence of large calcified or attenuated plaques at stent edges are the predictors of stent edge dissection. Additional stent implantation is mandatory when dissection extends to an arc of more than 60 degrees and or more than 3 millimeters in length. So back to our patient, post-PCI, echoreal no brachial effusion. Patient had otherwise unremarkable hospital stay. Is doing well on subsequent 3 and 6 months follow-up. So we are able to manage the dissection successfully. Catheter-induced normal LED artery dissection, stent edge dissection, and radial artery dissection. So you and me were incredible, tremendous, best of the best, like Mr. Donald Trump. So my take-home messages: management of complex dissection can be very challenging. Stenting is still the preferred treatment in most cases to restore coronary flow. Emergency cabbage is an effective alternative treatment. It is essential to have a clear algorithm for treating this complication should it occur. This is my hospital, and I'm happy to be a part of this team. Thank you for this opportunity, and thank you for your attention.
Thank you, Shahin Kabir, for nice management of challenging dissection case. We have a shortage of time, so I like to request a few words to say about this case to chairperson Sarawat Jawan sir and Fazila madam sir. Sarawat sir, Fazila madam, can you say some few short comments on this case?
Thank you. Great case, very effectively managed. But for all our fellows, the learning should be that we shouldn't make any dissections. He has already told us what are the points that can lead to iatrogenic dissection. Another thing I feel is that when we are doing engaging the catheter through the radial route, sometimes if we are not gentle enough, the catheter might sort of jump and sit not coaxially, and at that time the iatrogenic dissection happens. So focus is important and we need to be as gentle as possible, but a great job. And just another word, I want to say Momen did a fantastic job, and he has his wife, Hanuma, is a very talented structural heart interventionist. I was wondering, did she take part in this intervention? And I also want to mention that Dr. Tawfiq Shahriar-Haq has done quite a few of these cases as well, and these are life-saving. They really make a difference when we put in a device for a DSR after MI. Great job, Momen, very impressive. And I wanted to know, was Ranuma present there? Just wanted to know.
Thank you, madam.
Professor Amal. Professor Amal, I like to add. Professor Amal?
Yes, sir.
Can you hear me?
Yes, sir.
Thank you, Dr. Shahin Kubir, for excellent case, not only for case, for decision as well as management. Whenever there is perforation, dissection with perforation, here there is also perforation. Whenever there is perforation or dissection up to the forearm, even up to the arm, you can manage in this way PTC wire, that is downsize wire. And what that downsize wire, you have pushed the catheter, engage the catheter, do the procedure. When coming back, you are seeing that it's fine. So, it has been sealed. One thing you should you could do over this, that is the cuff pressure, blood pressure machine cuff pressure over the hand, forearm, and few times, 3, 4, 5, 6 session maximum necessary. 10 minutes, 10 minutes, 10 minutes compression, 10 minutes of above the systolic blood pressure, or 5 minutes over the systolic blood pressure, 5 minutes off. And it will also tremendously help when there is massive perforation. And do not go, my idea and my comment is that do not go after injuring radial artery, same-sided ulnar artery. Though it does not carry go any problem, you may tell that many cases I have done ulnar artery, what it will go? There will be nothing. But you, at the same time, you can't say, I can't say that I have done thousands of cases, there will be no radial perforation. It is proved that it has been, it has occurred in your hand, in my hand, another colleague's hand. It can happen. So my comment is that never use same-sided ulnar artery after injuring radial artery, as because this radial artery will be closed. And on the ulnar artery, if there is any problem, there is a spasm, there will be hand ischemia, and if it closes, and it is a horrible condition, and entire hand will be in danger. So this is very important for doing injury to the radial artery. I shall not do on that side, ulnar artery. If necessary, opposite side. If necessary, a different date. Patient is our asset. So we have to face, and we have to give them pitch, and for that reason we have to show our experience as well as our learning. And you have also shown the LED dissection, that probably you have shown in one film, that further engage of the diagnostic catheter, which was not coaxial, it was on vertical upward, and that is why it. This can, the person who is doing angioplasty, he cannot say in his life that I have not perforated a vessel, I have not dissected a vessel.
Professor Benjamin, sir, thank you for learning point. But some Professor Jillu are asking one question, whether is he asking that the JL is a very safe catheter, never produce, almost safe, never produce dissection. Whether this dissection is happened due to dye injection or JL catheter manipulation in radial route. Why this dissection happened?
in this question, I like to tell that there is no catheter which is immune to develop dissection. You may dissect by any catheter, and routinely radial angiogram angioplasty is done by a single catheter, not Judkins right, Judkins left. Whenever we get problem, we do not able to engage the coronary. In that situation only, we change to the radial. We change to the diagnostic catheter Judkins. Otherwise, we do not use. I think so far my idea, or so far I know, all the institutes radial procedure is going on with this radial TIZ. It was previous, that is very good, of Terimo company, and now there is another in the market of Medtronics of different curves. That is also good. And why shall I go for diagnostic catheter Judkins? One catheter will finish the job. Left system, right system.
Thank you very much. It is time. Please, next.
Sir, 1 minute, sir. In reply, Professor Fazila Malik.
Thank you, sir. Thank you.
For your PhD, I discussed Dr. Tawfiq and Dr. Maharumov before attempting the case, because they have the experience. They already 5 cases done, and this is the 6th case in our country with successful VSR repair. But they are not present during the procedure. Dr. Ataul Haq, who are our pediatric cardiologist, was with me during the procedure. But they helped me. Their experience helped me a lot, because they have done already 5 cases. Total 6 cases. So far, only 3 patients are alive after doing the 6 cases, including my one.
Congratulations, Moment. Great job. Great job.
Thank you.
Yes, sir. Go ahead.
Thank you all. Thank you all. There is shortage of time. There is shortage of time, so I am requesting Dr. Shahida Nasreen to present his case. The case is primary PCI of anomalous RCA through TRA. Dr. Shahida Nasreen.
Shahida Nasreen from Ibrahim Cardiac Center.
Dr. Shahida Nasreen, do you hear me?
Probably not. She is not present.
So I am requesting Dr. Anisul Awal to present his case, my bifurcation challenge. Dr. Anisul Awal.
Sorry, sir, I'm here. I'm Dr. Shahla.
Oh, very good.
Okay.
Then Shahla Nasreen.
Shahla Nasreen.
Yeah. Can I share my?
Yes, we are hearing you and we are seeing your slides.
Okay, sir. No, this is not my slide, sir.
Okay, I'm stop sharing. This is my slide.
Okay, please stop your slide. Please stop your sharings. I'm starting sharing now.
Share screen. Shala. Yes.
Yeah. Is it visible now, sir?
Yes. Primary PCI and anomalous RCA.
Yeah. Okay. Let me start now. Honorable Chairperson, panelists, moderator, and learned audience. Assalamu alaikum and good afternoon. My topic is primary PCI in anomalous RCA arising from left sinus of valsalva to transradial route. So this is the background. Percutaneous coronary intervention of congenitally anomalous coronary arteries may be a technically challenging procedure. There is general belief that femoral approach is associated. Sorry, do you hear me, sir?
Yes, we are hearing.
Okay. There is general belief that femoral approach is associated with better chances of coronary engagement and better guide support during PCI of anomalous coronary arteries. The following case supports that radial access is effective for PCI of an aberrant right coronary artery arising from left sinus of valsalva, even in an acute setting. The patient details is he is a 50 years old male gentleman, hypertensive, dyslipidemic smoker, presented to us with sudden severe chest pain with back radiation for 3 hours. His EKG revealed ST elevation in inferior leads, echo revealed regional wall motion abnormality with ejection fraction 50%. His renal function, liver function, and other blood biochemistry was within normal limit except that of hypokalemia. CT findings was dominant tertiary anomalous origin arises from left sinus of valsalva, totally occluded from its mid part. LMS was normal. LTS proximal 60% stenosis. SX has distal 80% stenosis with distal OM branch 80% stenosis. This is his CAG revealed RCA arising from left sinus of valsalva with totally occluded from mid part. We used a guide catheter IL 3.5 and the Xion blue guide wire was used. A disc was deployed of 2.75 into 28 millimeter and it inflated up to 20 atm pressure with restoration of TRIMI 3 antigrade flow. The procedural details was our first guide catheter was IR 3.55 French but failed to engage. Subsequent catheters were GR 3.55 French, XP 3.55 French. Those attempts were also failed. Finally, we succeeded with IL 3.55 French guide catheter. The subsequent procedure was as usual. For successful engagement of anomalous RCA from left sinus of valsalva, we use the left main ostium as our landmark. Then we give anti-clockwise rotation to make it more anterior, and according to need we further push it to make it superior, because the commonest origin of RCA that arises from left sinus of valsalva is superior and anterior to left main. So the remarks are for primary PCI. It takes some time for the engagement of this anomalous RCA, which is not acceptable for this specific procedure, but still as we use transradial route, we can save some time from puncture and initial catheter negotiation. As for AMI condition, minute is muscle and muscle is life. So from this experience, we can use IL 3.5 guide catheter as the primary workhorse catheter with subsequent success. The literature review showed that coronary arteries arising from an anomalous origin are uncommon and encountered in only 0.2 to 1.2% of patients undergoing diagnostic coronary angiography. The incidence of an anomalous RCA arising from left sinus of valsalva is very low, ranging from 0.02 to 0.17% of diagnostic coronary angiogram. PCI for an anomalous RCA arising from the left sinus of valsalva does present a technical challenge due to inadequate guiding catheter support to overcome the acute rightward course of the anomalous RCA. This is the picture taken from the book of tips and tricks of an interventional legendary cardiologist, Dr. Shobhanan Rai, sir, who has shown that when RCA arises from the right sinus, it has different position, and when it arises from the left sinus, it may be at the level of left main or above or below the left main level. So the origin of RCA is an extremely variable course. So in conclusion, ladies and gentlemen, one useful tip to successfully engage the anomalous RCA is always using the ostium of the left main artery as a landmark. The operator advances this catheter to the level close to left main ostium and then gives an anti-clock rotation to make it anterior. This simple maneuver will engage the anomalous RCA orifice coaxially, which is confirmed by RA view, and usually the engagement is done in aleocaudal view. We used common guide catheter like IR, which is an easily available catheter in all cath lab shelf, treating this rare but difficult cases, therefore more practical even in AMI setting for primary PCI. Thank you all. Thank for patience hearing and give me the opportunity, and my acknowledgement to Professor Said Rahman Khan.
Thank you, Dr. Shahida Nasreen, for your presentation. Anomalous RCA origin, especially in primary KCA, this is very much challenging, and especially if it is arise from the left sinus of Valsalva. There is a shortage of time, so I am requesting Dr. Anisul Awal to present his case.
Assalamu alaikum and very good afternoon. Honorable Chairperson and distinguished panelists and faculties. My case is my bifurcation challenges. Double provisional stanting with left main stanting is my first case. This is a history of a pleasant woman, 55 years, hypertensive, diagnosed as an anterior elevation MI, thrombolized with STK and cardiogenic shock. She was treated conservatively and she was treated in another center and then referred to our center. ECG was there as a elevation, B1 to B4, and echo regional ultrasound present, and 45% was rejection fraction. We started the procedure with the heparin and we took the diagnostic and then we take the EVU. This is our angiogram showing there is some lesion in the proximal RCA, and in the left system there is lesion, diffuse lesion in the LAD, and also there is a lesion in the left main from the mid to the distal. So this is a long lesion, and we calculate heart syntax score, which was low, is around 21. So decided to intervene, and we had the challenge of doing this case. There is two potentially bifurcation. One is the LAG diagonal, and another is the left main and LCX. So we had the plan to do the provisional stanting. So we had both the vessels diagonal, and we first pre-dilate the lesion with a smaller balloon, and we take a larger stand, 40 size, 3 stand. And this was austere because of the economical condition. Though we know the fact that there is other stands, giants and other groups of the, we have the better result in left main, but due to economic strain, we have to go with the austere. And we checked that whether we can go with a 3.5 millimeter stand, we can go up to 4. So we deployed the stand, and there was some, in the mid part, there was some indentation. We take a smaller balloon, and we post-dilate, and also we did the pot, keeping in mind that so that we can wide opening. If necessary, we can go to the side branch rewiring. But fortunately, we found that diagonal flow is not interrupted and is the same symmetry flow, and there was no dissection. So we decided to leave it in that position. So we now concentrate to the left main stanting. Then we decided to have an overlap stanting, including the left main ostium. Now we have the two challenges. One challenge is keeping the patent of the LCX. We keep a wire in the LCX, and we have another challenge not to miss the ostium. So we keep a floating wire in the ascending outer, and we keep a 3.5 stand and overlapping with the first stand, and we with different orthogonal views to make sure not to miss the ostium and also not to overhang the stand outer. So we have done our stand, but we found there is some pinching of the LCX. So that's we decided we recross, and this time we recross to the distal start of the stand. And we take a balloon, 2.5 size, and we dilate, and we have a final kissing, and also we have done the final pop, and also we made a flare with this high balloon. So with this double provisional stanting, we made the patient stabilize, and she is symptom free, and we're happy with the result. But due to lack of the eyeglass facility in our center, we couldn't check the result optimally. So my next case is the decay crush. Is another mode of treatment of the bifurcation. This is another pleasant lady, 60 years. She was stable angina, and she has no regional ultrasound abnormality, and we start the procedure. This is her angiogram. This is a non-left main bifurcation lesion, Medina 111. So we decided upfront two stand strategy. So we wire both the vessels and pre-dilatation of both the branch, and stand deployment at the side branch, and we're keeping a few millimeters in the 2 to 3 millimeters, but in fact in this case a bit more in the main branch. First crush is done by the main vessel balloon, and then rewire through the crushed stem. Here we have to, in this case of decay crush, we have to go through the proximal start, or at least in the central. So we check in the scene view, in the stand view we have in our cath lab. So with this we check, and we found that this is we go through the proximal stent. So then we did the first kissing balloon inflation, and then we did the stent deployment at the left main in the main branch, and this we are doing the second crush with the stent. And after crushing, we did the port so that we can cross the wire to the stent strut, which is make easier. This time, proximal crossing is not mandatory, but still we have done this with to the proximal. And then the question arises second keys, and we sequentially done with the side branch, usually in the high pressure first, and then we sequentially do by 12 atmosphere pressure in the both, and then after that we do the final port. And with the final part, as you can appreciate, the carina, nice looking carina, and there's a nice result. So that's our final result. So few words about the bifurcation, a branch that we don't want to lose. This is a reference diameter is more than 2 millimeter, and this is not uncommon. 16%, procedural complication 9%, re-stenosis 36%. This is the algorithm. Most of the cases 80% we can do by single stent, but when the two bifurcation and the larger stent, we may have to go with a double stent. And the GK crush is the preferred nowadays. There are the advantages and disadvantages of different techniques of the double stent. So GK crush is ideal technique, and it can be compatible with the 6 French and transradial also. In definition, 2 trial upfront 2 stent is superior. And my take-home message: doing challenging cases like complex cases in a resource-limited center like us needs logical approach, perseverance, and teamwork. GK crush, knowing every step and following them is mandatory for optimum outcome. And in left main ostial stenting, it is crucial not to miss the ostium, and at the same time not to overhang the stent in aorta. With these few words, thank you very much for your kind attention.
Thank you, presenters. Due to shortage of time, we would not like to discuss more. The name of the awardee will be declared at the last session, at the end of the last session. I think this is the time for prayer as well as lunch. I think we can conclude the session here. Anything, any chairperson or any panelist, any 1 or 2 questions?
Professor Amal, can I take 1 minute?
Okay.
Thank you, Professor Amal. So our speaker is Dr. Anisul Awal. The bifurcation lesion is already presented, and you find in a resource-limited center at the level of medical college, the limitation is not only with the technique in the center, also the limitation with the financial aspect of the patient. So in this particular area with so many limitations, we are going with some of the complicated cases, as already mentioned by our esteemed professor Anisul Awal. So, and Anis did a long time endeavor in performing this bifurcation lesion, and ultimately he came out very successfully. He performed this case as well as some of the cases with bifurcation lesions with good TIMI flow and good symptomatic improvement of the patient. So thanks to the BSCI authority. Thank you.
Thank you, Dr. Praveen. Now I am requesting Professor Mahuraman Babu to comment here something. Professor Mahuraman.
Thank you. It's my great pleasure to be a part of this fantastic academic session. I congratulate all the presenters for their excellent and time-worthy presentation. Each and every case was unique with lots of learning objectives. Our young and energetic cardiologists are doing a very good job. I also congratulate the President, Professor Fazlur Rahman, and Secretary, Professor Mir Jamaluddin sir of BSCI for arranging such a nice, vibrating conference. Thank you all.
Now I'm requesting, thank you, Mahuraman Babu. Now I'm requesting Professor Fazlur Malik to conclude the session. Thank you.
Good cases, and thank you, and hope to see you again after the prayers and at 5 o'clock. Great session, wonderful cases. Really enjoyed them. Thank you.
Thank you, madam. Thank you.
We conclude the session.
Session শেষ করে দেব। শহীদ শহীদ খন্দকার শহীদ প্রফেসর খন্দকার শহীদ। Thank you all the participants up to near about 1:30, 1:35. We must congratulate all the participants, speakers, foreign speakers, and our moderators. So you have glorified the program, and that is why we are grateful to you, and we are also grateful to my members of the Bangladesh Society of Cardiovascular Intervention. They have given us tremendous support physically, technically, and from their heart, and that is why we are grateful to my society members, all the members also. Now by the permission of scientific secretary, as because our Fazila is the chairman of the scientific committee, with due permission from her, I can conclude this session for the morning time, and evening by 5 we shall come back once again. Thank you. Thank you.
Thank you.
One declaration, madam.
Yes, please.
Declaration.
First, second, third will be awarded in the last session in the evening. So I do request chairperson to make the result. First, second, and third will be given award in the next session, that is in the evening, in the last session. Thank you all. Thank you very much.
Thank you. Congratulations to all.